Type 1 diabetes is an autoimmune condition in which the patient's own immune system attacks their pancreatic beta cells which produce insulin. Insulin is a hormone responsible for lowering blood glucose levels via GLUT4 transporters. Hence, without pancreatic beta cells, blood glucose levels will rise up, leading to hyperglycemia. There are many current treatments for diabetes, but there is no specific cure. For instance, insulin injections and pumps can be used to restore insulin levels and prevent hyperglycemia. However, these are temporary solutions for a chronic illness. Considering the fact that the pancreas cannot secrete its own insulin, how do we provide a self-sufficient cure to this problem? Researchers have discovered that islet cell transplantation may offer a long-term solution to type 1 diabetes when the patient's own beta cells have been destroyed. The patient's own somatic cells can be employed in vitro to be transformed into insulin-secreting beta cells. Encapsulation of the islets offer an alternative to immune suppression where the capsules act as semi-permeable membranes that hinder the immune attack of transplanted cells. Importantly, the capsules allow for diffusion of oxygen and nutrients to the encapsulated cells and also permit the diffusion of insulin out to nearby capillary networks. In this video, we'll propose a novel idea which incorporates a microchip to the encapsulated islet cells to combat the accumulation of T cells, which is often associated with cell encapsulation methods.
So here's how it goes. The patient's somatic cells, such as fibroblasts, will be induced to function as beta cells by transcription and growth factors in vitro. These will then be encapsulated in an allogeneic polymer coat and inserted surgically near the major vasculature of the pancreas. We use self-somatic cells as this will avoid the risk of immune rejection, and allogeneic is a biocompatible and stable polymer. It will not hinder the proliferation of beta cells. It has small pores about 4 to 12 microns, which allow for diffusion of nutrients, oxygen, and metabolic waste. However, T cells will not be able to cross as they are too big at 7 micrometers. Incorporation of TMTD can prevent immune rejection of the coat. As T cells cannot enter the capsule, they may accumulate in the vasculature surrounding it, causing harmful blockage of blood flow. To combat this, a microchip will be inserted into the pancreas to detect the amount of T cells present by sensing proteins on their surface, e.g. CD4 and CD8. Once a threshold is surpassed, nearby lymph nodes will be signaled to produce chemoattractants like CXCL12 to attract T cells away from the vasculature. This proposed idea could provide long-term treatment for TD1 that is physiologically analogous with functional beta cells, negating the need for constant glucose monitoring and insulin injections. The use of self-somatic cells reduces the chance of immune rejection of the transplant and the need for immunosuppressants, while the novel chip reduces T cell accumulation in the surrounding vasculature. However, downfalls also exist. Currently, this method has only been trialled in animal models with minimal trialling in humans. Additionally, the need for surgical chip and capsule implantation is a complex delivery method and arises the risk of infection. Despite the use of alginate, obtaining sufficient oxygen diffusion for cell survival has proven problematic and requires further research. Finally, the chip can fail, leading to T cell accumulation, and an effective way to ensure the battery life of the chip whilst causing minimal inconvenience to the patient is also unknown. Despite these drawbacks, funding can provide further development of the proposed treatment to assess the identified limitations.